So initially when I give this task, I thought it's a very difficult topic. Most of us, like an oncologist, no one likes to treat sarcoma because of the age, they are young. You don't have much modality, and most of them, they progress regardless to whatever therapy you are giving. So when was reviewing the literature, I came to this articles, which is Targeted Therapy in Sarcoma, Challenging the Challenge. It shows you just one thing, that it's a very hard subject. So sarcoma that are driven from connective tissue and bone. It's a very rare tumor, less than 1%. They had a lot of somatic mutation. Though we have that, we are lacking of targeted therapy in those. We have Gleevec, and we've heard that yesterday by Dr. Abdullah Sherm, so I'm not going to talk about just tumor. Most of the patients are young, and 50% they develop metastatic disease. In soft tissue sarcoma, there is more than 80 subtypes, so it's very hard to treat these patients. So in 1940, the first time they discovered the electron microscope, it took them another 40 years to have subclassification, which was primitive classification for the soft tissue sarcomas by this pathologist. So chemotherapy, which is the standard of care, as far as we know, there's a few sarcoma are chemosensitive, like synovial, fibrosarcoma, round cell liposarcoma, rhabdomyosarcoma, and leiomyosarcoma. Though we know this fact, we still give some of the patient chemotherapy in spite that know that they are not really chemosensitive, but we have no other options. So again, looking at the drug approval from the 80s to 2014, this is 30 years to have only modest improvement on the overall survival, only 6 months improvement, starting from ifosfamide, trabectedin, bazobenib, and eribulin, so that we don't have any success with chemotherapy. Looking at the mutation, this is like having tons of mutation. You can concentrate on only a few of them, which is the commonest, like cyclin-dependent kinase 2A, 2P, and 4, retinoblastoma, and TP53. This is the commonest. If you concentrate on that, probably will find a good targeted therapy. If you're looking at the cyclin-dependent kinase, it will develop in breast cancer, but not yet in sarcoma. So they try to figure out what the cytogenetic classification of sarcoma. They figure out the 3 classification: variable complex abnormal karyotype in 50%. It occurs in spindle cell, leiomyosarcoma, myxoid fibrosarc, polymorphic lipo, and polymorphic rhabdo. And reciprocal translocation in around 30% in myxoid round cell liposarcoma, synovial. Amplification usually in liposarcoma, whether it's well differentiated or de-differentiated. If you look at this table, I'm going to use the mouse because the pointer doesn't work on the screen. Looking at this is showing you what kind of mutation, and if we have an actionable mutation or actionable drug can work on this mutation. First one, this is alveolar sarcoma, and it's common in females, so they have translocation at the X chromosome. The drug working on that, TKI and MET inhibitors. I have 3 patients, and Dr. Faisal, we're sharing 1 patient. And to tell you, in fact, these a very rare tumor, and the TKI doesn't work, and even MET inhibitors. Those patients now receiving immunotherapy, 1 of them have complete response. The angiofibrosarcoma, they have translocation. Unfortunately, we don't have any actionable mutation. In angiosarcoma, by default, we know that anti-angiogenesis is going to work. On chondrosarcoma, they have the ADH1 and 2 somatic mutation, so ADH1 inhibitor can work on that. Chondrosarcoma, TKI and TUR inhibitors. Clear cells, we have the MET inhibitors. Dermatofibrosarcoma, we can use Gleevec on that. Desmoplastic, we have no drug for that. In uterine sarcoma, we have the anti-estrogen therapy. In endothelial hemangic endothelioma, we use anti-angiogenesis. Giant cell sarcoma, I don't know how much you're seeing giant cell sarcoma, but we have like 20 cases in our institutional, and they are receiving denosumab, and they are doing quite well. I'm going to jump just. This is inflammatory myofibroblastic sarcoma. ALK inhibitor can work on that. Fibromyxosarcoma, they have the translocation. Again, in myxoid chondrosarcoma, no drug available. And everyone who's treating sarcoma, they know chondrosarcoma, if they are not a low grade, it's hard to treat. Low grade, let's go to the surgeon knife. high grade, it's very hard to treat. Usually we treat like Ewing sarcoma, and sometimes we fail. In extraaxial chondrosarcoma, we have no good therapy so far. Myxoid liposarcoma, we have chemotherapy or PI3K inhibitor. Coma, which is prevascular endothelial sarcoma, mTOR inhibitors. We have one case in our institution. Pigmentous villus synovitis, CSF inhibitor can work in that. Solitary fibrous tumor, angiogenesis, synovial sarcoma, bazobenib, and we know synovial sarcoma is a chemosensitive, as I mentioned before, but we don't have good chemotherapy work on that. A liposarcoma, we have the cyclin-dependent kinase inhibitors. So targeted therapy, we have one of the medications that presented in the last ASCO, Cytogenetic, which is multikinase inhibitors. It works mainly in the vascular endothelial growth factor receptors. They plan to do for 36 patients, but they reach 48 patients. They divided between placebo and between the drug, and the primary endpoint was the reduction in the tumor size. And if you draw a line at the zero in this spider plot, you will find all the light blue is below the zero line, so have significant reduction in the tumor size. If you look at the progression-free survival, the drug gave around 10 months, where the placebo gave around 4 months. If you look at the survival, overall survival, if I draw a line at 12 months, 94% were alive because of the drug, and for placebo only 46%. Olatinib, this is a phase 2 single arm. This is also another TKI. It works in ABL PCR, which is proving in treatment of chronic myelocytic leukemia. They give the drug only single arm in patients who progressed on previous treatment, only on soft tissue sarcoma, and the primary endpoint was progression-free survival at 12 weeks. If you look at the number, it's very appealing, and if you focus on alveolar sarcoma that we don't have a standard of care, they have 76 for a week, which is very great for this kind of cancer. Regorafenib, we all know regorafenib, especially the GI oncologists. We know that proving colorectal and also an HCC. It is also multikinase inhibitor. Again, it is a vascular endothelial growth factors inhibitor, so that's specific about it. It works very well on synovial sarcoma. If you look at the leiomyosarcoma, almost like 3 times doubling on the progression-free survival, but in the synovial, almost 6 times doubling in progression-free survival. In the liposarcoma, if you feel like there is no much of improvement. And the other curve is showing all the other sarcomas. So you see this modest because they lump everything together. So we know for a fact it works on synovial sarcoma. If you look at the survival, the hazard ratio was 0.49, so almost 50% reduction of risk of death. Uglatimab, which is a new antibodies immunoglobulin G. It is selective for platelet-driven growth factors alpha. That works very well in combination with doxorubicin. And in this trial, they were compared the doxorubicin with the investigational drug on combination with doxorubicin, and it improved almost 1.5 months in progression-free survival. In terms of overall survival, the improvement almost like 10 months. The beauty of this drug that they did not look at the subtype yet, on which specific subtype it will work well, but this is probably the only drug have a good survival advantage among all the subtype of soft tissue sarcoma. Here again, bazobenib, we know bazobenib improved and treatment of sarcoma, of soft tissue sarcoma. In combination with Gemzar, it did show a modest improvement in overall survival. But for a fact, we know bazobenib doesn't work on a patient with liposarcoma. But in here, if you look on the curve probably on your right, that liposarcoma, they have significant improvement in overall survival, almost like 20 months. So this specific combo can be to the liposarcoma. Immunotherapy, which is the future, so we have to touch base on the immunotherapy. Nivolumab and ipilimumab been tried on a design that combination with nivo and ipilimumab, they will get 4 cycles, then the patient will go to nivo single. The other arm will be just nivolumab again, and they allow the crossover. In terms of improvement in progression-free survival, we know the combo is better, almost like doubling, 4.4 months versus 2. And in terms of overall survival, also there is an improvement. Almost like 54 patients are alive at 12 weeks versus the single agent nivolumab, only 40% will be alive in 12. Given the fact this is heavily pretreated, they did not go to the subtype, so it will be hard to give this drug to a specific type of patient. Looking at the Pembro, I think the design in pembrolizumab was very smart because they divided the patient to soft tissue sarcoma and bone sarcoma, and this is the way that we treat our patient. Even we know the subtype, but we say this is a soft tissue and this is a bone-related sarcoma. So they give the Pembro. They will do a biopsy before stratification. They will do it at 8 weeks, and if the patient progresses, and this is optional. So if we look at the soft tissue sarcoma, the progression-free survival was 18 weeks. In term of overall survival, it was almost like 48 weeks. And if you look at the polymorphic sarcoma, the overall survival did not reach. So this is the commonest type of soft tissue sarcoma that we see. In terms of bone sarcoma, the survival and overall and progression-free survival was modest. And progression-free survival was 8 weeks, which is most of the patients that progress on the therapy. In terms of overall survival, they reached 55 because of the chondrosarcoma. And again, having said that chondrosarcoma, we don't know what type of chondrosarcoma, so I'm not really sure how much we can get a conclusion from that. For us, like if we want to give immunotherapy, probably will be for soft tissue sarcoma and not for bone-related sarcoma. So I'll conclude with certain thoughts that we don't have like a specific oncogenic driver in spite of having a lot of mutation. Finding one target can fit this big group of soft tissue sarcoma, it will be very hard and it's work in progress. I think the combination was very brilliant between pazopanib and Gemzar. Maybe we can do that with immunotherapy in the future. And this is the future of sarcoma. This is a multi-sarc trial. This is what's going on. That presented the last ASCO. There will be a one-to-one randomization. They will start do next gene sequencing, and based on that, they will stratify the therapy based on the next gene sequencing. And some of the patients, they will do nothing. They will go to the standard of care. And for the first quarter of 2017, you can see there was 16 drugs available to treating subtype of sarcoma. You can name it. Everything is there, like MET, ALK, PARP inhibitor, EGFR inhibitors. So I think the treatment of sarcoma will be changed. It's not will be like before, we give one medication can cover more than one type of sarcoma. So I will wait for this trial, and I think this is what about which is precision medicine will be in the future. And thank you.